Hello everybody, this is part one of two lectures covering the interdisciplinary teams and the role of the dietitian. And we will be covering in this first one the role of the dietitian along with some information on the role of the nurse, the pharmacist, the physician, and the hospital administrator. So basically, there's a lot of push now to start teaching students, health professional students especially, in their educational curriculum, how to work with others so that they can then take that to their professional environment. Now, this is something that dietitians have been taught for years, but they're seeing so much more value in it that most departments now are including this as well, because if you can understand right from the very beginning when you're learning about everything, how to work and play nice with others, then when you take that into the real world, it's easier for you because it comes naturally. You'll recognize your patient's needs and you'll be able to collaborate with others in order to improve the outcomes that you're trying to get to happen. And overall, there are four kind of overreaching areas, and this is from an article that I'll post on Blackboard for you. There'll be two that I'll have on there if you want to look more further into these. But this article talks specifically about when we work with interprofessional teams, or if we work with a group of health professionals, we will be able to use informatics better. And that informatics is basically just technology married kind of with healthcare, so that we have like electronic health medical records, we have educational systems that are all online and can be transferable from one location to the next. They also will help us to have more patient-centered care. One of the really fantastic things, if you get an interdisciplinary team that works really well together, everybody understands their role and how they can work together to improve this patient's care, then the patient will do so much better than if each person of the team is in their own silo and doing their own thing without communicating or collaborating. Quality improvement, we are in an age now where patients will shop for physicians, they'll shop for pharmacists, they'll shop for hospitals. And so you have to make sure that that patient is always satisfied, that you're giving quality care so that they'll, if they, heaven forbid, if they get hurt again, they can come back and they'll be just as satisfied the next time. And if you can give this holistic approach that everybody's working together, it just appears to the patient that it's better quality. And finally, everything is evidence-based. You'll learn this in our courses here at EKU, and you'll learn as you go into the profession. Everything that you do and everything that the other healthcare professionals do is all supported by evidence or by scientific research. I can't just go out and decide to tell people to take essential oils every day for their health, because there's no scientific evidence to support that. Everything I recommend and everything that I do for the patients has to have some foundation in science. It has to be proven significantly with scientific research that it's beneficial. This is from the Academy's article that is posted on Blackboard, and I'm only going to highlight a couple of things. But it's really getting into the heart of the dietitian, the nurse, the physician, and the hospital administrator working as a team to improve the nutritional status of the patient. Food is so much more than just nutrition. I mean, it makes people happy, it can make people sad, it can make people angry, and so your role as a dietitian in the hospital is not just, I'm going to go give people a diet all day long. It is improving their health status. It might be getting them out of the hospital faster. It might be putting them in a better mood than they were before. So you can't just look at yourself as, well, I'm only here to change people's diets, because that's not at all. That's just a small piece of what you're going to be doing. So we're going to go over these 6 principles and look at them from the perspective of all 4 of those health professionals. So the first principle is creating a culture where nutrition is really important. every hospital that you will ever be in will have a completely different culture. I have worked in 2 major hospitals in Lexington, and both of them were significantly different as far as their perception on nutrition. Some of them will value the role of the dietitian. Some of them, they could care less if you're there, and that's just the way that it is. Until you prove your worth, they're not going to put you on a high priority. So if you can help create a good culture where nutrition is important, if you can go out there and speak confidently about what you do and how you can help that patient, the other practitioners and the other health professionals will value you a lot more. If the nurse and the physician and the hospital administrator understand what you're doing and how you can improve patient outcomes, then they will give you basically what you need to be successful. The second principle is kind of setting the stage for what you're going to do. You have to say, I'm the nutrition expert. The nurse should not be teaching the patient a heart-healthy diet. That is outside of their scope of practice. That is what I do as a dietitian. You should be going out regularly and communicating with the health professionals. Don't be afraid to go up to the physician and say, hey, I just saw Mr. Jones, and this and this and this should happen with his diet. So you have to constantly kind of interact with them. You can't be shy. You have to be part of this team, and you have to go around regularly when the physicians and the nurses and all the other health professionals go around. Now, the hospital administrator in their role should support you to continue to learn, but also support you teaching others. For example, when I was at St. Joe, I led a class for nurses on the appropriate diet for heart failure. Types of things like that should be supported by hospital administration so that everybody in the facility knows that the dietitian is here, that this is what the dietitian can do, and when you shouldn't step over our toes. Principle 3, so one of the really, really important things that we'll talk about this semester and next semester is making sure that all patients that need us, that have nutritional issues, maybe they're malnourished, maybe they're not eating, maybe they've lost a significant amount of weight, that they see us as soon as possible. All facilities are required to have a screening process in place, which we'll talk about in a couple of weeks. But they should all have somebody in the facility, and a lot of times it's nursing, that screens every single patient within 24 hours of admission. And that screening then gets sent to the dietitian for the dietitian to further evaluate what's going on. The hospital administrator needs to support that. It needs to make sure that the dietitian is involved, and the nurses and the physicians also need to make sure that the patient gets seen by that dietitian. And a lot of patients, they may come in and they're fine, but 3 days later they get worse and their nutritional status gets worse. The physician and the nurse need to recognize that, and they need to say, okay, wait, now we've got a problem with nutrition. Let's call the dietitian. Principle 4 relates to the dietitian. Now that you've seen this patient and you've recognized what's going on with them, you want some things to change. It might be their diet needs to change. It might be the way food is delivered to them. It might be the location of where they eat. Whatever it might be in that facility, you can communicate with the nurse and the physician to get those changes accomplished in order to make sure that the nutritional status of this patient gets better and that patient can get out of that facility. So the nurse makes sure that your orders are all done. They may be communicating with you back and forth saying, the patient didn't get their boost today and they were supposed to. It was on the order, but it didn't get up here. The physician may be saying, all right, well, I'm not going to put this patient in PO if you feel like you can kind of handle what the complications of this disease are going to be. And the hospital administrator needs to make sure that you have the right to create your own orders, write your own orders. This is something that has been passed, and so dietitians can now write diet orders, and we should be the ones that do that. It should not technically be the physician, because we would understand better as a dietitian the disease process and what kind of diet would fit best for that patient. We also should have a better understanding of what's available in our kitchen in the hospital or in the nursing home that can get to the patient. Communication. We have to always have clear communication that is in the chart and that we are presenting to the other health practitioners that are with us. So a lot of the coding and the billing, all the reimbursement that we'll talk about in a few weeks that happens in the hospital comes from what you have in your note. So if you put down that a patient is malnourished, you better have evidence to support that they're malnourished. You have to be able to communicate verbally with the physicians and the nurses in a nice, respectful manner. You know, if they're doing something they shouldn't do and they're stepping on your toes, you don't walk up to them and say, hey, look, that's my job, but out of it. You have to be very professional in what you say because you have to work with these people every single day. You have to have a way for them to get in contact with you if needed and to feel like they can come up and talk to you and say, hey, Mrs. Jones isn't eating very well. We've been doing everything you say. What other kinds of ideas do you have? Because, you know, it's not going to be perfect every time you see a patient. And discharge nutrition. So a lot of times patients are discharged. They go home or they go to a nursing home or they go to a rehab facility and things just kind of get dropped. You know, you may have the patient on this really wonderful meal plan in the hospital and they're eating well and their disease is under control and it's managed, and then they leave and everything kind of just disappears. You know, the next physician that sees them doesn't even know what diet they were on, or the nursing home has no clue what foods they were receiving, and so they have to start from scratch. It's really important that you have a good transition care plan so that wherever they end up, they know exactly what was happening nutritionally with that patient. Now, fortunately, with the electronic medical record, that makes it easier. But, you know, I've been known to, if I knew a patient was going to be transferred to, let's say, Cardinal Hill Rehab, I would sometimes call that dietitian and say, hey, look, this patient has a lot of complications. We worked through it. These are the things we were doing right before they were discharged. Because that way the dietitian there doesn't have to start all over and figure out what works for that patient. So constantly educating and teaching when they're discharged and when they're going to follow up with whoever's next. The nurse and the physician should include this. You know, they're kind of in charge of what gets transferred, and they should make sure that nutrition and what was happening nutritionally with that patient gets transferred with the patient. And the hospital administrator needs to be really focused on transitional care and making sure that there is communication between the inpatient, what was happening in the hospital, to what's going to go on outside of the hospital. In the next slide, in the next YouTube video, we'll talk a lot more about the other health practitioners that we will work with outside of the nurse, the physician, and the hospital administrator.